So good, good morning, everybody. So I had the task in 10 minutes to bring the unsolved problems in diabetes, and to start with that is, of course, to realize the magnitude of the problem. And it's certainly now there has been never a disease affecting as many people at the same time as diabetes, and that's the charts from the International Diabetes Federation from 2014. And one of two important points are to be realized here. One is that it's not like so that it is mainly affecting North America and Europe. It's affecting also the emerging countries. And what is particularly concerning is that although a lot are already diagnosed with diabetes, there are still a lot and a majority which are undiagnosed. And why is diabetes such a problem? It's a leading cause of heart disease and stroke. In our countries, I mean North America and Europe, it's a leading cause of blindness and increasing cause in the rest of the world, leading cause of kidney disease, nervous system disease, and non-traumatic lower limb amputation. So tremendous consequences of diabetes, and therefore rapidly, before we say what could be done there, in one slide, what is the pathogenesis of the disease, how does it happen? And we have very specialized cells, as you probably all know, the so-called pancreatic beta cells, which are localized within the pancreas as islets, and they sense minute by minute the changes in glucose, and accordingly insulin is released and uptake by the so-called insulin-sensitive tissue. Now, when you have overweight, then the fat tissue increases more and more, and probably as a kind of protection, it becomes resistant to insulin. It means that probably because the tissue are overloaded with food, they start not to react anymore to insulin, and for a certain time in pre-diabetes, the beta cell can react by increasing in function and mass, but eventually this will fail, and the pancreatic beta cell will not be able to adapt anymore, and so the glucose will not be uptaken in the insulin-sensitive tissue, and you will have a relative or with time an absolute deficiency in insulin, leading to increased glucose with all the toxic consequences that I have mentioned. And there is a lot of speculation how this failing of the insulin producing beta cell occur, and why is this insulin resistance occurring. Just one word, one of the emerging hypotheses with more and more data is probably that this is an inflammatory process ongoing there. So what are the unsolved problems in diabetes? We know that best, of course, if we would have changes in a lifestyle to prevent diabetes, but also to treat diabetes at any time. I'm speaking about type 2 diabetes, and any time you can improve the disease with lifestyle intervention. Then we have drugs, and the only one which is uncontroversial is metformin, but after that, we have several drugs, but no one has been proved to be better than the other. And one of the problem is also that we do not have yet any so-called disease-modifying drugs. So you can improve the blood glucose, you can to a certain extent replace insulin, but you cannot change something in the progression of the disease. And even if the patient change his lifestyle, the disease will continue to a certain extent, and eventually all patients, if their life long enough, will need insulin. And the second thing is the comorbidities of diabetes, which I've mentioned, and ideally a drug should not only tackle diabetes itself, but the comorbidities. So just two words on each of these patterns. One, to the life intervention. This is not something you can standardize. It's really to look which patient you have in front of you, what is his whole socioeconomic background, and then to motivate him to change his lifestyle. And it's a tremendous difficult task, but we do not give up in daily life. but it would be extremely helpful if we would have also on top of that anti-obesity drugs, just to promote. So that would be, I would say, one way to solve, or at least to tackle the disease in a serious way, would have to be anti-obesity drugs. We have one now which more or less is good but not sufficiently efficient, which is a GLP-1 agonist. The second is really how to implement also these lifestyle changes. I will not speak about that, although I would love to, but then I would require 3 hours. But the bottom line is that we should not say that food is something bad, and it's a wrong way, in my opinion, to start to give taxes on certain food or things like that. We should legalize the food and put them in something positive, and the patient should learn again to eat and to enjoy in a positive way. The second thing in lifestyle is that we should implement more activity. And this is a picture from our emergency room. That's our major concurrent, and this is the way we address that. This is a simple bike, and when we have new onset patient with type 2 diabetes, we symbolically take away their place where they are lying, and give them the feeling it's not just by being like that and receiving drug that you will change something in your disease, but you have to become active, and we demonstrate to them what activity can do on blood glucose. So this is our attempt, and as said, we try every trick, and anti-obesity drugs would help us in many cases, because it's a very strong drive. Again, for question of time, I will not expand too much, but it's not just that the people have bad thinking or are lazy and so on. It's a very strong drive to have access to food, and the unfairness is that population which didn't have access to food for many, many, many years, they have genetically been selected to have more aggressivity towards getting the food and also to using them better. And now it's a kind of backfire from the nature that now that there is more food, especially disease patients have now more difficulty to control their body weight. As said, after metformin, we have limited data to guide us. The dramatic need would be long-term study, head-to-head comparison, optional sequence of drugs, all questions that maybe enter into discussion if there is interest here. And last is that we would need disease-modifying treatment, and as I have mentioned, also treatment which will tackle the complication of the disease, and that is our bias. We believe that the best way to tackle the pathogenesis of the disease is to tackle the inflammation. And with that, I will give to the next unsolved problem, and maybe there will be a better solution that we have currently. Thank you.
The chance to have some questions. Is there some question from the audience? Because I would like to do this after the talk. So I did understand that the prevention is one of the big issues for preventing diabetes. What do you expect now from the nanomedicine community? Do you expect some nano-formulated anti-obesity drug with less negative side effects to treat diabetes much efficiently?
Yeah. I think very specifically to the nanomedicine, I'm not knowledgeable about nanomedicine, but I understand it's a way you can also deliver drugs. And we know some molecules which increase satiety. The incretin hormone are one, there are also other one, and it might be a way to design drugs using nanomedicine that would target these drugs, give better pharmacokinetic to this drug. So that would be probably the way I would advise to this community.
Okay.
And the other one, sorry, is for the complication and the progression of the disease. Again, the same principle, anti-inflammatory drugs that are today quite going all over the body, which could be targeting some specific tissue like the beta cell or like the kidney, eyes, and things like that.
Okay, so thank you very much. Are there... Oh, here's a question. Donald?
From the point of view of unfairness, there is also the issue of the socio-economic situation of the poor parts of our cities. In Glasgow, there are parts of the city that life expectancy is 15 years less than the norm, and they are next door to each other. And a situation, I remember asking a church minister how many of your congregation could afford organic food. He said none of them. So the question of how far you can actually address lifestyle change with people who are really at the bottom end of the poverty scale, even in our own cities, let alone developing countries.
Yeah, but basically the same principle. That's really the point, that the bad food, if I may say that like that, is cheaper. And if you have a stressful life, you don't take the time to eat properly. Then you take these food which are unprocessed, which do not provide satiety, which are full of calorie and all these problems. And basically the same problem that we see between the so-called developing country and the other countries, the same also within the cities or within the population. And it's really like that today's the more poor people, they are the ones who suffer more from obesity, because the food has changed like that vegetables are more expensive than some fatty food, and it's really to give a priority to that.
Yeah, there's a large number of patients now receiving long-term anti-TNFs as anti-inflammatory. I don't know, but is there any data there to suggest your hypothesis re-inflammation is true?
Yes, so definitively. So the anti-TNF is a story by itself, because it has been shown 20 years ago that it has to do something with type 2 diabetes. Then there were the first clinical study which were conducted in a very bad way without going into details. Then it was left. And now that we have a lot of patients treated with anti-TNF, we can have some sub-analysis. And for example, there has been 2 large studies showing that patients with rheumatoid arthritis, if they get an anti-TNF compared to another drug, with the anti-TNF they are less inclined to develop diabetes. But there is still missing a proper placebo-controlled study on anti-TNF versus placebo, but based on a large amount of animal studies and on these observational studies, it's quite probable that anti-TNF would be a very good candidate to prevent or treat type 2 diabetes.